वही तो मैम फालतू का सेटिंग।
Hello. 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 Hello.
Hello.
Am I audible?
Yes, madam, you are audible.
Great. Thank you. Thanks.
Hello. Hello.
Hello. This is Dr. Sundari.
Yes, madam, we can able to hear you.
Yeah, thank you.
Okay, welcome, madam. Hello. Good afternoon to everyone over here and a warm welcome to all of you. I, Professor Isma Shamim, on behalf of the organizing committee and OBG department, welcome you all in today's webinar on adolescent gynecology. At the outset, I thank Almighty Allah Subhanahu wa Ta'ala for making us capable of conducting a national webinar on adolescent gynecology on the eve of International Women's Day. As you all know that adolescence is a transitional state of physical and psychological development that generally occurs during the period from puberty to adulthood. Adolescence is usually associated with teenage years, but its physical and psychological expression may begin earlier and end later. Physical growth and cognitive development can extend in early 20s. Age provides only a rough marker of adolescence, and scholars have not agreed upon a precise definition. Traditionally, it includes ages 10 to 19, but an expansive definition includes ages 10 to 24 years to account for a more comprehensive understanding of this phase of life. The description of adolescence bulughat is mentioned in Unani system of medicine under the heading of Asnan Arba, 4 ages. So basically the 4 phases of the life of the human beings have been classified as Sinde Numo, that is the growing age, which extends from the birth to 30 years. Sinde Shabab, it is also known as Sinde Wakuf, adulthood, which extends from 30 to 40 years of age. Third is the Sinde Kahulat, that is the age of decline, which extends from 40 to 60 years. Sinde Shekhuka, that is the age of superannuation, which extends from 60 years of the age till death. So here again, Sinde Namu, that is the growing age, is further classified into 5 categories. So in this growing age, the body continues to grow and has hot and moist temperament. So the first phase of Sindamu is the Sindakulat, that is infancy, which extends from birth to the 4 years of age. Second phase is the Sinde Sabha, that is the childhood, which extends from 4 to 9 years of age. Third phase is the Sinde Tararu, that is adolescence, which extends from 9 to 14 years of age. The fourth phase is the Sinde Balugat, that is puberty, which extends from 15 to 25 years of age. And the fifth phase of Sinde Namu is Sinde Pata, that is the last stage of growth, which extends from 25 to 30 or even 35 years of age. After this, no further growth of the body is possible. So out of these 5 phases, the most important is adolescence and puberty. So the problems which occurs in this adolescence and puberty will be discussed in today's webinar. As you all know that adolescent gynecology is an emergency specialty at the intersection of pediatrics, which includes pediatric endocrinology, gynecology, surgery, dermatology, psychiatry, genetics, and so on. So it thus addresses a wide spectrum of diseases from the newborn period to adolescence. The gynecological problems encountered in children and adolescents are often both medically and psychologically complex and thus require a highly skilled and coherent approach. The adolescent is no longer a child, but not quite an adult, poses a particular problem to the healthcare providers. Adolescent gynecology services offer specialized gynecological care for girls and teens that encompasses preventive healthcare education as well as medical and surgical care for common to complex issues. So let's see what are the gynecological issues which usually occurs at adolescence. Menstrual problems in the form of dysmenorrhea, amenorrhea, oligomenorrhea, or HMV. Sexually transmitted infections, gynecological care for young women with chronic medical issues, early or delayed puberty, endometriosis, labial adhesions, pelvic pain, ovarian cysts, PCOS, sexual health and safety, trauma to the genitalia, vulvar lesions or ulcers, vulvovaginitis. Patients will be referred to the adolescent gynecology for examination and anesthesia for the foreign bodies and examination for adolescents with physical or developmental disability. Surgical evaluations of the management may also required for ovarian cysts, vulvar lesion, congenital anomalies of the female genital tract, chronic pelvic pain, endometriosis, and so on. I just want to highlight here some of the congenital anomalies of the female genital tract which are mentioned in the Unani system of medicine. The first one is Ratak, that is considered imperforate hymens. That is the absence of the vaginal opening in amenorrhea, which could be congenital or acquired secondary to the adhesions or stricture following the injury. Second thing is incidade homeraham, that is cervical stenosis, which may occur as an abnormal growth. It may be due to the abnormal growth, adhesion, stricture, and may cause amenorrhea or dysmenorrhea. So it was mentioned in the classical literature that amenorrhea may be when menstrual cycle does not start, even though a woman has passed the usual age of menarche, that is primary amenorrhea, or menstruation occur, but due to the obstruction in the passage, the menstrual blood fails to come out of the vagina and remains in the uterus, that is amenorrhea secondary to Ratak or imperforate hymen. Even the concept of clytomegary was mentioned as asthma, buzzer, and labral adhesions. All these are the features of the congenital adrenal hyperplasia, and it was mentioned in Jarahati Zahrawiya, which is the Urdu translation of the treatise Kitabul Isri, which is written by renowned Unani physicians Abul Qasim Zahrawi al-Bikasis, who is the father of surgery, and he has invented almost all surgical instruments. Apart from that, the steak gonads, one of the causes of the female infertility is the steak gonad, which is mentioned as Khusyatur Raham ka nafis ya chota hona, that is nothing but the premature ovarian failure or steak gonads. So these were some of the Unani concept which was mentioned regarding the gynecological abnormalities that takes place at the age of adolescence. So I, on behalf of the organizing committee and OBG department, acknowledge the support of our esteemed director, Professor Abdul Wadud, who is the organizing chairperson of today's event, for providing us opportunity in conducting today's national webinar on adolescent gynecology. I also acknowledge the support of our HOD, Professor Wajia Begum, who is the organizing secretary of today's event, for constant support and encouragement in conducting today's national webinar. As you all are well aware that Department of Ilmul, Qabalat, Amraz and Niswan is one of the founder department of NIM, started in 2004. Since then, we have been striving for reaching the zenith in research and patient care. To the date, our department has endorsed 87 research scholars. Most of those are recruited in the reputed teaching, research, and patient care course across the country. As you all know, that the department on academic platform regularly conduct journal clubs, seminars, symposiums to keep the students updated in subjects since 2004. Department has to its credit more than 300 research and review papers published in the various national and international peer-reviewed index journals with high impact factors, and more than 11 books are authored by the faculty of the department. Faculties of the department has achieved more than 32 awards to their credit. With this brief introduction of the department, I warmly welcome the eminent speakers of today's webinar. I welcome today's eminent speaker, Dr. N. Sundari ma'am. She is the retired professor, HOD of the MS Ramaiah Medical College, presently working as a senior consultant at MS Ramaiah Hospital, Bangalore. I also welcome Professor Wajia Begum, working as an HOD of the Ilmul, Qabalat, Amraz and Niswan, and IIM Bangalore. I also welcome all registered delegates from across the country. I once again welcome you all in this national webinar on adolescent gynecology. I hope you all gain thorough insight and better understanding of the topic at the completion of the webinar. Thank you. So without wasting any time,
You unmute, Dr. Ismat, you are muted. Please unmute yourself. Unmute yourself.
now I invite the first speaker, Dr. N. Sundari ma'am. She's working as a senior consultant at MS Ramaiah Hospital. She was the retired professor of MS Ramaiah Medical College. She has worked as a former HOD of MS Ramaiah Hospital. She has been affiliated to BSOG, FOXI, AGOI. Her areas of interest are high-risk pregnancy, preventive oncology, teaching. She is the president and founder of an NGO that is Mahati Trust. She works for cervical cancer prevention, awareness among rural and urban women of Karnataka. Sundari ma'am will speak on the topic PCOD in adolescent girl. She is a very dynamic personality who needs no introduction. One thing I will tell you regarding Sundari ma'am, whenever we invite her as a guest speaker, she graciously agreed to accept our invitation and contribute her insight and knowledge. And we are fortunate enough to have such a renowned speaker with us. Now it's over to Sundari ma'am.
Thank you, Dr. Ismat Shamim, for very kind words. And I should thank you for keeping confidence in me and then calling me repeatedly for your educational programs. Can I share my screen, please? Is it seen? Screen is seen?
Yes, ma'am.
Okay, am I audible?
Yes, ma'am, you are audible.
Please. Today's topic, as she has extensively told us about the adolescents and what are the various stages of development and all. My topic today is only adolescent PCOS, because it's every other girl comes and says, they themselves come and say, Madam, I have PCOS. You know, this has become a routine for us from the youngsters to hear that word. And some scan is done, and then there's somebody just a diagnosis as PCO, and the girls, it remains in their mind, and wherever they go for every problem, they attribute the PCO and they say, I'm a PCOS. So let's see what is, I'm only speaking adolescent PCOS. I'm not touching upon a reproductive age woman or the other ages, as she has given 5 groups of the development and various phases of life, but I'm touching only the adolescent PCOS. Now, this is the flow of my talk. If the time permits, I'll be talking about all these aspects of adolescent PCOS. As adolescence age, this is 10 to 19 years is called adolescence. In that early adolescence, this is by the WHO definition. Early adolescence is 10 to 14 years, and then that's a time they are just getting into menarche phase, and a middle adolescence getting adjusted to the various changes in their body and they're in the mind also. And then, of course, late adolescence, they are ready to get into the adulthood and other aspects of life. So that's the way it is divided. Now, PCOS, if you take, that is polycystic ovarian syndrome, we call it polycystic ovarian disease. We don't say usually. Why we say syndrome is it has got so many other systems are involved in this. That's why we call it as a syndrome. So it is mainly an endocrinopathy, because the main problem is the hormonal milieu, change in the hormonal milieu, starting from hypothalamo-pituitary ovarian axis, and the brunt is on the ovary where the hormones are secreted. There's a lot of change in the hormone. I can't go into the details of the pathophysiology here. I'll be only dealing with the clinical aspects of it, which we need to know. And it is polygenic. There are a lot of genes are involved in this. And not only that, multifactorial, hormonal, and metabolic dysfunction. So all these things, that's why we call it as a syndrome. Now, it's extremely heterogeneous and a complex disease, because every girl or every woman, reproductive age woman, or a perimenopausal woman, if you take even age groups, they exhibited different signs and symptoms because of this. PCOS may be there in every one of them, but at each age group, and even each person in the same age group also exhibit different types of problems with this. That's why it is extremely heterogeneous and a very complex problem to deal with. Now, what is PCOS? It is a most common endocrine and metabolic disorder. It can start at the menarche, even before menarche. The girl reaches before menarche, she would have gone in for amenorrhea. 15 years, she has not got her periods, and it's a primary amenorrhea. Even one of the causes could be PCOS. And as early as 11 to 12 years, it can start, and it can range from 15th year to 45 until they reach menopause. Even we call about the menopausal PCOS. The woman who had PCOS, and we call them as menopausal PCOS because the effects will still remain in a postmenopausal woman also. That means throughout the life of a woman, once they are diagnosed as PCOS, they will have the ill effects of it unless they are very careful to control it. Then the main problem in the PCOS is androgen excess and ovarian dysfunction. The prevalence is 6 to 10%, very high prevalence. We have 6 to 10% of the women or the girls can have the PCOS. 20% of the secondary amenorrhea and 50% of the oligo-ovulation, whoever has got, they must be having a PCOS. It's a very prevalent disease. Now, what are the causes? It's an inheritance, heterogenetic inheritance, as I told you again. Heritable X-linked form can be there. Autosomal dominant inheritance can be there. It is seen that PCOS, the girl is there, either she would have had her mother as a PCOS, or the siblings have got, female siblings could have had PCOS. So this runs in the family. And then if you take the genes, it's a lot of genes have been identified which are causing this problem. Mainly it is EYP 21, 17, 11 year, 19 genes. Definitely they are involved in the genetic variations involved in causing this PCOS. Now, coming to the environment and epigenetics have got a major role on this. This epigenetic modification, there are mainly 3 modifications occur in the epigenetic. That means epigenetics is not the genetics, is not the genetic alterations, but the genetic alterations won't occur, but other modifications will occur, but this is temporary. It can be reverted also to normalcy. That is epigenetics in short. There is a DNA methylation, histone modification, and decoding of RNA. These are the main 3 things will happen at the cell level in the epigenetic process. So the fetal exposure to the androgens and anti-Mullerian hormone in the womb itself can cause them to prone to become PCOS. That means it's like a fetal programming. We call it for the diabetes. When a mother has got diabetes, we say fetal programming occurs, and the fetus will program, her fetus body will get programmed so that when it comes to the birth and the adolescent and early adult life, they can become diabetics. That's what it's a very good theory, a very famous theory. It is the same thing applies even in the PCOS also. Fetal programming occurs, epigenetic modifications occur there, so that they are prone to get this once they become adolescents. And children who are born with fetal growth restriction, they are more prone to develop PCOS. Then intrauterine programming is a successful factor, has been hypothesized, as I told you. Now, another thing added to this, there may be programming, yes, you are prone to, but if my mother is diabetic, I am prone to become diabetic because I had the fetal programming probably, but there are other things which will influence also. Everybody will be prone, but few will get, few may not get it. Why? That's our lifestyle and the socioeconomic factors. So the socioeconomic factors play a major role. Gut microbiota, this gut microbiota alterations occur depending on the food habits of us, and then the lot of toxins which are there in our food or in the environment, they also add up to this. And obesity, physical activity. Now, why the PCOS is very high now in our girls, which we have not seen 10 years back, because there is absolutely no physical activity in our girls nowadays. And the habits, unfortunately, what they think that it is, they think in the society, they have to have such habits. Unfortunately, they're all not healthy habits, and the type of food, burgers, pizzas, what not, all these things together, they make them more prone to suffer from PCOS. They may have a genetic predisposition, intrauterine programming would have been done. But if these things could be modified, all these things, if they can modify, probably they get away without suffering from this PCOS. That is more important for us. This is like this. The PCOS is multifactorial. So the genes may be there, but the environment is very, very important. In which environment they are brought up and how they are brought up, what habits they have got, food, exercise, obesity, body composition, all these things. What they do is these things will cause insulin resistance, which is the main pathological factor for all the problems in PCOS. So if you could avoid this, probably we avoid suffering from PCOS. Now, there's a type of PCOS, there's a classification based on the phenotype. There are 4 A, B, C, D is there. The classic PCOS phenotype AB is the menstrual dysfunction they'll have, hyperinsulinemia, insulin resistance, hepatic steatosis, metabolic syndrome they will suffer in their later life, and increased AMH levels. These are the characteristics of, mainly that means these are a standard, typical, clinically evident and biochemically evident PCOS. Now, there's something, they don't have an ovulation here. They don't ovulate. Because of the hyperinsulinism and insulin resistance, ovulation, they're oligo-hypo-ovulatory. Now, there's something called ovulatory PCOS, that is a phenotype. So here, mild abnormality in insulin levels and its resistance. Hirsutism scores are pretty high in them, and metabolic syndrome they have. Occur in higher socioeconomic status women usually, but they may ovulate, but they have a milder form. Here it is pakka, everything is very clinically evident, but here milder form. Still they have their menstruation also, but still they may suffer the hirsutism they may come with. Now, there's other non-androgenic PCOS. Mainly we said androgenism and the anovulation are the two things, but without that also PCOS can be normal androgen levels, lowest metabolic dysfunction, regular cycles with intermittent irregularities. Why we say this is, there are so many phenotypes, but it's a difficult, here and here, it's difficult for us to diagnose them as PCOS. If we don't diagnose them and then advise them properly about their lifestyle, probably they will switch over to here. So the prevention is better. Probably we have to identify. This is very evident. We can identify them easily, this A and B phenotypes. But these two phenotypes, it's very difficult for us to clinically diagnose that. Now, this is the combinations of PCOS. This is, I just put it various descriptions by various people. Mostly we follow the Rotterdam criteria. And this is anovulation and then the androgen excess combinations, how it will be. It is said in a different varieties. Now, classification based on the phenotype A, this is exactly, I told you, this polycystic ovaries in the A, hyperandrogenism, oligo and anovulation will be there. And about the menstrual history, I'm telling. Phenotype B, classical PCO, it is also called normal looking ovaries, oligo, anovulation, hyperandrogenism. So, these two, as I told you, clinically, they are pakka PCOS. Now, the phenotype C, polycystic ovaries are there, but normal menstruation, the hyperandrogenism alone is there here. Normal menstruation, menstrual irregularities are not there. Then D, non-androgenic PCO, polycystic ovaries, oligo, anovulation, but no hyperandrogenism. This is again difficult for us to diagnose. So, these are the varieties of PCOS what we have. The diagnostic criteria, Rotterdam criteria we follow, and universally, of course, most of us follow that. That is hyperandrogenism, menstrual irregularities in polycystic ovarian morphology. Any two of these three are there, we can label them as PCOS. Now, the hyperandrogenism, what will be there? Clinically, you see hirsutism, acne, even if not hirsutism state, initially what they'll have acne. The girl who never had the acne, she develops a lot of pimples over the face and the back. And androgenic alopecia, many a time the mothers are so concerned, they come and say, she's losing the hair, madam, like anything. It was so thick hair and she's even a baldness is coming for her. They say, and there's seborrhea, a lot of sweating, and then a lot of this one will be there. And ultimately, they may go for virilization also. Virilization is the distribution of the hair distribution, the male pattern, it could be there. Biochemically, when you analyze them, they'll have total of free testosterone high, free androgen index is high, 17 alpha hydroxyprogesterone is high, and prolactin, the thyroid stimulating hormone, and the DHEA. These are the things which you have to do. These things we do because to exclude other causes of hyperandrogenism. We have other causes for hyperandrogenism. I'm saying from the idiopathic to tumors. So we need to say it is to say that this adolescent has got only PCOS, nothing else. We have to do all these hormones so that they exclude adrenogenital syndrome, late onset adrenogenital syndrome, and then the tumors, and then the Cushing's. There are so many other endocrinopathies are there which will be presenting like this only. So in them to differentiate these enzymes are important. Those things are physiological hyperandrogenism of puberty, idiopathic hyperandrogenism, polycystic ovarian disease, and androgen produced. These are the differential diagnosis, and that's why we do all those hormone assays now. What are the menstrual irregularities? 60 to 80% of these girls will have menstrual irregularities. This may start from menarche itself. First cycle she had. After that, she never had cycles. The mother says after that she didn't have, madam, 1 year since she attained menarche, but she never had a cycle. She's so worried. The mother brings the child. Irregular cycles, delayed puberty itself, 15 years, she has not attained menopause. Maybe one of the causes primary amenorrhea, as I said before. Then it could be primary or secondary. See, this is one thing which we have to remember is nowadays there's one more problem we are having here. Secondary amenorrhea she had. Few cycles after that, she is not having any cycles. That can be either PCOS or what's happening to us is there is something called a premature ovarian insufficiency. Girls are going like menarche. Very few follicles they are born with. and they spend out the follicles. After some time, at a very early age, they stop menstruating. When we do FSH in them, it's pretty high, it's a menopausal. I have now, right now, 2 girls, young girls, they are in the premature ovarian insufficiency. So whenever they come with secondary amenorrhea, we have to rule out the possibility of a premature ovarian insufficiency, and we have to make sure that it's only PCOS. Now, prolonged cycles, absence of spontaneous, this is the major problem I face with every day. 6 months, 8 months, she has no cycle at all. Only the hormonal withdrawal. You give hormones, she'll get the withdrawal. And she stops the hormones, no cycle at all, and no menstruation at all. That also can happen. Of course, the other spectrum is she will have abnormal uterine bleeding and heavy menstrual flow. 33% of the admissions of these girls, PCO girls, are due to AUB. And irregular spotting months together, 1 month, 2 months, madam, I've been having little spotting. These are all the menstrual irregularities they can have. Now, coming to the polycystic ovaries, yes, there is a polycystic ovarian morphology, it is called. That doesn't mean if you have ovarian morphology, always, somebody does the scan and say polycystic ovaries. So the girl thinks that she has got a polycystic ovarian syndrome. But having a polycystic ovarian morphology is not equal to polycystic ovarian syndrome. We have to have true criteria among the 3 true criteria to diagnose them as a polycystic ovarian syndrome. One, of course, is the ultrasound features of the polycystic ovaries. The other one, either they have to have menstrual irregularities or they must have hyperandrogenic clinical signs. Without that, just having this like this, the ovaries, we should not say it's a polycystic ovaries. Most of the sonologists now say there is a peripherally arranged follicles and a thick stroma, so it is polycystic ovary. That was in the beginning, Rotterdam criteria was that. Now the criteria has changed. It is only more than 20 follicles in each ovary, each measuring 2 to 9 millimeters. You have to count wherever they are distributed. It is not the periphery alone. And the thick, the hyperechoic stroma is no more considered as a sign of polycystic ovary. Or if you don't do this, when you do the ovarian volume, that we have to do 3D only we have to do. When we do correctly 3D ovarian volume, if it is more than 10 ml, that ovary is also called polycystic ovary. These are the criteria have changed now, but all over, even the whole of Bangalore, all the sonologists give peripherally arranged follicles and the thick stroma, polycystic ovaries. I think high time they have to change, and then the criteria should be looked into carefully before labeling the girl as having a polycystic ovaries. Now, coming to adolescent PCOS, what are the problems we encounter? Diagnosis is always challenging, as I told you in the beginning. Ultrasound should not be used for diagnosis less than 8 years of menarche. This we have to remember, because they may have, because of the FSH and LH are not oriented to each, and then the hypothalamo-pituitary ovarian axis is not mature yet in them. Then there's a lot of follicles can be seen like that, mimicking a polycystic ovary. So the criteria is ultrasound should not be used for diagnosing polycystic ovaries in a girl who is less than 8 years after her menarche. This is very, very important for us. It is not done. That's why every girl is labeled as polycystic. Irregular cycles without abnormal biochemistry need close follow-up. Only irregular cycles, because again at the menarche, first 2 years, they will have physiologically irregular cycles. Can I know how much time I have, please? Anybody can tell me, Dr. Isma? Can I know how much time I have?
3:30, ma'am.
30 minutes, is it?
Yes.
Oh, thank you. Yeah. Irregular cycles without abnormal biochemistry. See, this is important because first 2 years, irregular cycles are very, very common. As the mother brings, and then she had one cycle, Madam Menarche, and after that 1 year, she has not have any periods. I said 1 year, don't follow. And you look at the girl, she is not obese, she is not having any hyperhirsutism. Just, they counsel them and ensure that this is physiological. Once in 3 months, 6 months, she gets menarche. Yes, she can get it. But if she bleeds heavy, you please bring her because otherwise she'll become anemic. Otherwise, it is okay for her until 2 years because the HPO axis matures only after 2 years of menarche. So until then, just don't bother, we'll tell them. Now, the assessment of biochemical hyperandrogenism is useful in diagnosing PCOS where clinical hyperandrogenism is absent. Now, the situation like this, the girl comes with a very irregular periods and she's a little overweight to her age and nothing else is there for her. So in that time, probably to know to label her as PCOS or not, we may have to do biochemistry. Whereas if you take an adult, like she's in the reproductive age, 25 years, 30 years, she comes with irregular periods. We don't need to really do the biochemical aspects of the hyperandrogenism, that is a biochemistry. We needn't have to do. A clinical picture is enough to say ultrasound you have done. That's okay for them to carry on because our aim is something different and their problem, what they would have come to us is different. But here, these girls, we need to correct them from the beginning. That's why we need to know about it. So biochemistry may help us when we have doubt about the PCOS. Girls who have features of PCOS but do not meet diagnostic criteria are considered at increased risk of developing PCOS. Okay, so these girls have to be under close surveillance because anytime they may go for full-blown PCOS. Now, the menstrual irregularities, as I told you, adolescent secondary amenorrhea, this we have said already, and the hyperandrogenism, acne, mild to moderate severe, it is classified as, and it is persistent and unresponsive to topical therapy is definitely due to hyperandrogenism and PCOS. I mean, whatever they use, the creams and the lotions, whatever they use, it is not been giving any relief for them for the acne. That means probably the underlying PCOS, and this is hyperandrogenism is there. Hirsutism, Fuhrman-Galway score we have, and that score has to be used to know the severity of the hirsutism. Now, the menstrual irregularities, physiological, as I said, it could be common during early years of menarche. So it is the diagnostic dilemma. Hirsutism can be physiological at this age. That also, again, we have to remember. And then they may have a familial hirsutism. Most of the girls, yes, your mother had, your sister had, your aunt had. Yes, madam, my mother also have got a hair on her legs. I mean, that becomes a familial hirsutism rather than a pathological hirsutism. That also we have to remember. Anytime moderate to severe hirsutism, if is a cause for concern because that may be pathological, we have to think. Now, irregular cycles and ovulatory dysfunction, when do we call it as irregular in an adolescent girl? Normal in the first year post-menarche as a part of the puberty transition. 1 to less than 3 years post-menarche, we can take it as physiological. Less than 21 years and more than 45 years, again, it will be physiological. 3 years post-menarche to perimenopause, it will be okay, again, it can be taken as physiological, less than 21 years, less than 21 days and more than 35 days, or we say less than 8 cycles per year is called oligomenorrhea. 3 years post-menarche, also we can accept it as normal, not beyond that. 1 year post-menarche, more than 90 days for any one of the cycles is abnormal. We have to think. Primary amenorrhea by age 15 or 3 years post-talaq. After the breast development, 3 years also they didn't get the periods. That also we have to think that it is abnormal. So these are the things we have to consider when we are talking about menstrual abnormalities in these adolescent girls. Special features of adolescent PCOS. PCOM, that is a morphology. Polycystic ovarian morphology is not a diagnostic criteria for PCOS in adolescent girls. Scan is not necessary for diagnosing PCOS. Hyperandrogenism and ovulatory dysfunction are the diagnostic criteria here. A definite diagnosis of PCOS is not needed to initiate treatment. That's important. We don't need to be pakka to diagnose PCOS in them. If he comes with a menstrual irregularities, there's no problem. If there is no contraindication, we can just put them on OC pills for some time. It really does some good than leaving them alone. So treatment can be initiated to prevent the coma. This is important for us. In spite of not having a definitive diagnosis, treatment can be initiated in the adolescent girls. Same thing we don't do in the adults. Symptom treatment, regular and frequent follow-up are the recommendation. Symptom treatment, she comes with some symptoms, we have to treat, whether we have diagnosed it as PCO or we have not diagnosed, but still we can treat them. Like in PID, pelvic inflammatory disease, because we have to be energetically treating them. A little suspicion, whether you have any evidence or not, please treat. Otherwise, the morbidity will be very, very high. Same way here, if they have symptoms, if there is no contraindication, treat them off with the OC pill so that morbidity will be, by the time they get a full-blown PCOS, probably we miss the bus and the morbidity will increase. So in adolescents, the PCO evolves. That means it may be very, very, very mild. That means they may not have all the criteria at the beginning itself. Slowly they may be evolving. So if you have a suspicion or she comes with any of the dysfunction, ovarian dysfunction, better to start treatment rather than waiting her to get into a full-blown PCOS. Other clinical features which are not taken as a diagnostic criteria for PCOS is obesity. Obesity is not equal to PCOS. Non-PCOS obesity is also there. And PCOS, lean PCOS are also there without obesity. So we have to remember that. Acanthosis nigricans also is a typical, the pigmentation around the back and then the nape of the neck and the molar areas on the face, all this. But it is not a diagnostic criteria for PCOS. See, there are many conditions they can have acanthosis nigricans. Then same way, hyperinsulinemia and psychological problems. These are the other symptoms or other problems which a girl with PCO will have. But these are not taken as a criteria for diagnosing PCOS because they can be there without PCOS in many other conditions. And insulin and PCOS. This is very important. Whenever we talk about PCOS, we say insulin resistance. Now, what do we mean by that? Majority of the women with PCOS have insulin resistance. If they are obese, they'll have 95%, 70 to 95% of them can have the insulin resistance in the body. Even lean PCOS without obesity, without overweight, also they have up to 30 to anywhere from 30 to 75% of them can have insulin resistance. That means whenever there's a PCOS, you have insulin resistance. What do we mean by insulin resistance? There must be high insulin production in the body because the body is resistant to the insulin. High insulin is both a sign and physiological drive for PCOS. This is the insulin resistance we say for the diagnostic sign. And what happens when there is insulin resistance? That's the one which triggers off the whole hormonal change in the hormonal milieu in the ovary. So it is a physiological drive for PCOS. It impairs the ovulation, facilitates testosterone production by ovaries, results in type 2 diabetes and acanthosis nigricans. These are all what can happen with the high insulin resistance. Test to diagnose the insulin resistance is fasting insulin and a HOMA-RI index. Now, this is the latest index which they calculate. Insulin glucose ratio, anything more than 4.5, I think, is taken as. But we don't need to really estimate to diagnose PCOS. Unfortunately, I see people asking for fasting insulin, insulin glucose ratio, fasting sugar. Yes, we are justified in asking because these people will have a hyperglycemic or impaired glucose tolerance they will have even at the younger age group. So we need to do a fasting and postprandial sugar, but there is no need because these are not the diagnostic criteria as we have seen now. We don't need to estimate these things. Now, what is insulin resistance if they have? What should we do? The diet control, exercise, weight loss, metformin, and myoinositol are the ones which are given to reduce the insulin resistance. Now, how do we diagnose? Diagnosis of hyperandrogenism, hyperinsulinemia, and then, of course, the clinical pictures. Now, how do we diagnose hyperandrogenism? Total and free testosterone. This is very, very important, but unfortunately, there should be a standard procedures have to be done for this. Some chromatography assessment has to be done, especially for the testosterone, which very few laboratories in Bangalore do it. So just like that, asking for testosterone is not ideal because many laboratories, they may not be doing it. 17-hydroxyprogesterone will tell us whether it's adrenal problem or it is PCOS. The same way androstenedione. These are the hormones, male hormones, which we need to estimate and see whether she is PCOS. She is producing, she is hyperandrogenic. Now the TSH, PRL, FSH, LH and elevated LH. Elevated LH is the other one which is there, characteristically will be there in PCOS. Because it is elevated, FSH is low, so it is a ratio is changed to 2:1. So that is again a characteristic, but that used to be initially, we used to talk about FSH LH ratio 2:1, but no more, it is taken as a diagnostic criteria. Now, what is taken as diagnostic criteria is the total of free testosterone, and the testosterone index is taken, and then 17-hydroxyprogesterone estimation, and DHEA also they have to do. Probably here I have not written DHEA also we need to do. Then coming to the fasting insulin, insulin glucose ratio, blood glucose levels, oral glucose challenge test. These are all the ones to know about the insulin resistance and the hyperglycemic state. Now 17-alpha-hydroxyprogesterone more than 200 milligram per deciliter definitely will rule out the other causes, and then it will say that it will be PCOS. Okay, these are the ones which we need to do as a diagnostic modality in adolescent girls. Now, the other comorbidities are metabolic syndrome. She'll have an impaired glucose tolerance. And then type 2 diabetes, very early they can develop. Psychological problems are very many in these girls. They come and say, Madam, I have PCOS. And every problem they try to attribute it to the PCOS, poor things. They have anxiety, depression, and low esteem, especially if they are obese or overweight. They have a very low esteem for themselves. And the obesity, increased insulin resistance, anovulation, hyperglycemia, and menstrual irregularities it can cause. These are the only in adolescent I'm talking about. When you go to the adults, reproductive age, infertility will be the main problem. And the perimenopausal menstrual irregularities and AUB will be the problem. And of course, peri and postmenopausal uterine cancer, endometrial cancer is the problem. Now, the long-term sequelae, metabolic consequences will be GDM. They can develop diabetes during pregnancy or type 2 diabetes, sleep apnea, cardiovascular disease, and dyslipidemia are the sequelae, metabolic sequelae. Reproductive problems, anovulation, infertility, poor quality ovum, and increased need for ART. And once they conceive with all this, recurrent pregnancy loss is a major problem in them because the quality of the ovum is very, very poor in them. So there can be recurrent pregnancy losses. Then the psychological problem, as I told in the beginning, in the previous slide, compromised quality of life, anxiety, depression, and the low esteem. The cancer risk, endometrial hyperplasia, and these are all the long-term sequelae if we have not attended to the PCOS and we allow the girls to go with that. Now, strategies to reduce the risk is exercise, diet, and weight loss. That is equal to whole lifestyle modification. This is needed for the PCOS to be under control. Now, how are we going to manage this PCOS cases next? There's no cure for PCOS. Many people come and say, Madam, my doctor has treated me. They said that I'll cure the PCOS. Please remember, it's inherited hormonal change in the hormonal milieu in the body. There is no treatment for PCOS. Then what do we do if there is no treatment? Treatment is aimed at managing the symptoms and improving the quality of life in them. In adolescent age, she has a menstrual irregularity problem, you have to attend to that. Reproductive age, woman has got an infertility problem, we have to attend to that. And the perimenopausal age group, she has got a AUB menstrual irregularities, and then reproductive age, and any age they can become with acne under hirsutism. We have to take a call on those things. And a postmenopausal woman who had a PCOS, we must be closely watching them for development of endometrial cancer. That means whatever is the problems at each age group with the PCOS, those are the problems we are addressing rather than a PCO per se we cannot address. We have to remember, maybe the initialist Team Leventhal who described in 1935 about this condition, they used to do the wedge resection of both the ovaries to reduce the hormones. But I don't think now we can anybody venture that. Even now we do the follicular, this one. That is at the last resort we will do that. Surgical management for the PCOS. Otherwise, we have to manage medically. That was what they used to do, wedge resection of the ovaries. It started, and then in our days when we were students also, it was done, wedge resection. So now we don't do that. Now the management is general management and pharmacotherapy. General management is a lifestyle modification. In that we have diet, exercise and nutritional supplements. And pharmacotherapy, we have a oral contraceptive. I'm talking again about the adolescent PCOS, metformin and spironolactone. We'll just see lifestyle modification to reduce the sugar and carbohydrates, weight management and regular exercise. This is very, very important. What is the effect of this? It improves the menstrual irregularity, decreases cardiometabolic risk, reduces androgen excess, can all be achieved with weight loss. All this can be done with weight loss. Once we do this, weight loss can happen. This is the first line of therapy in any overweight PCOS girls. They come and say, you give me some medication. No. First thing is a lifestyle modification, exercise and diet control. We have to spend some time with them to know what sort of diet they consume, what is their daily activity we should know. Once we know that, accordingly, whether if it is not sufficient, definitely when they are obese, it will not be sufficient. It will not be an ideal food they will be taking. The physical activity may not be sufficient. That's the reason why they put on a lot of fat. So we need to counsel. Counseling is very, very important in these cases. The key factor, as we say, the lifestyle modification is the first line of therapy. Even before this, the counseling is the main important thing, or a main aspect of the treatment is counseling, because these are young girls. They want to eat, they want to run around, they want to sit with the movies or with the WhatsApps now. Only on computer or WhatsApp they are all the time. So they think that that's a life for them. Very irregular hours of sleep, getting up very late, going to bed very late, eating whatever they want. When they are just on these things, maybe some chips, something like that. All these things we have to tell them. That is very, very important. So to make them accept that lifestyle change, counseling is very, very important. These at a young age, they may not think of the future risks. They just want to enjoy the life in whichever way they want. And now, you know, the whole world goes through something and they also want to be like that. Whatever be their culture behind and wherever they are come from and what culture they have been brought up, all that material. X does, I have to do. Y does, I have to do all these things. Just they want to mimic. All others, they want to copy and do it. In such situation, it's very difficult for us to explain to them and make them understand what is needed and what is they are doing is wrong, is very difficult. So in my view, counseling of the adolescents is very, very important. That is the first step of management. Now, the weight and BMI calculations, 18 is, for the Asians, it is less than 18 is underweight and 18 to 24 is taken as normal for us. Anything above 25 is overweight and anything above 30 is obese. Again, obesity classification is 30 to 35 is class 1. This is BMI. Class 2 is up to 40 and 40 above is class 3 obesity. So we must know where we stand with. Now, weight reduction benefits, enormous amount of benefits we have with the weight reduction. Not only PCOS, the whole lot of life can be very healthy if we only reduce the weight. It reduces the insulin resistance straight away by 50% without any drugs, restore the ovulation, regulation the menstrual cycles, improve fertility, reduce pregnancy complications like PIH and RPL, whatnot, improve health during pregnancy, reduce the risk of cardiovascular disease, risk of endometrial cancer, and improve emotional health, that is self-esteem, will be improved and the anxiety and depression will be reduced. So weight reduction is the key. Then pharmacotherapy, OC pills, yes. In adolescents, the first drug, if at all we need to give drugs apart from the lifestyle modification and reduction of the weight, yes, OC pills have to be given for this. It provides contraception if they are sexually active, acts on HPO axis and reduces ovarian androgen production. It's very good for us. Increases the sex hormone binding globulin and decreases the androgens. The progesterone reduces the chance for endometrial cancer. and regularize menstrual irregularities and reduce the bleeding also. So vocipils have got enormous amount of, this is the first line even for hirsutism. This is the first line of treatment what we need to give for the adolescent girls. Now, next is the metformin. I don't think we will use metformin for the young adolescents. Useful in adult PCOS for treatment of weight, metabolic and hormonal outcomes. For management of metabolic problems, if they are diabetics, type 2 diabetics, yes, metformin is good along with PCOS if they have high risk for metabolic. If suppose the woman is, there is an impaired glucose tolerance and this girl is obese and she has got a family history of diabetes and she is PCOS, probably young girls also we can give metformin to prevent her to become diabetic. Adolescents when lifestyle do not achieve the goals of BMI, reducing the BMI, and they have BMI more than 25, probably we can add up the metformin for them. The vocipils and then anti-androgens. Vocipil can be an anti-androgen, as I told you, for even hirsutism. First line of therapy is vocipil. If it is not being controlled with vocipils, then we can add what is called spironolactone. Aldosterone derivative, it can be used. Together, they may reduce the hair growth in them. Now, what some myths about it, the PCOS, you did something to cause it. It is not a self-made PCOS, as I told you in the beginning, in the first few slides, it is programmed when the child is in utero. So nothing to blame ourselves. Oh, it's because of my attitude and my lifestyle I have got PCOS. Yes, it becomes evident, but you have been programmed to get it. But if you know that and you can stop your lifestyle, if you keep it regular, probably you may not suffer. To a certain extent, yes, it is. If you lose weight, you can get rid of PCOS? No. There is no cure for PCOS. We told that. Only women with overweight can reduce the weight so that the problems of PCOS can be reduced or minimized. Then you can't get pregnant if you have PCOS. Yes, to a certain extent it is. It is difficult to conceive when you have irregular cycles and PCOS because cycles are irregular, ovulation is not happening, and even the ovum quality is not good. So all this, and there is insulin resistance, so implantation problems will be there. With all that, difficulty in conceiving is not there. That doesn't mean that it is impossible. ERT techniques are there. Certainly, women can become pregnant. PCOS affects only overweight women? No. We have lean PCOS also, so it can affect anybody. But obesity and overweight add fire to the fuel. That's what we have to remember. So adolescent PCOS is a challenge in diagnosis and management especially. Counseling plays a major role in convincing the adolescents to accept the management protocols. That's important. I thank Ismat Shamim and Dr. Kausar Fatima and whole team from the Unani Institute of Medical Sciences for giving me this opportunity. And I thank all the viewers for patient listening. Thank you, all of you.
Thank you, ma'am, for a very informative and deliberate information on adolescent gynecology. Ma'am has given a clear pictures on adolescent gynecology right from the beginning of pathology, clinical features, diagnostic criteria, long-term consequences. More important, the management, especially the lifestyle management, which is considered the first line of treatment for the patients with PCOS, apart from the pharmacological treatment. As ma'am has rightly said that the PCOS, there is no cure for PCOS. We can only give the treatment for the symptomatic relief. Thank you, ma'am, again for your excellent information, deliberations on adolescent PCOS. There are some questions in the chat box.
Yeah.
If a patient with a delayed periods, having normal BMI, having multifollicular ovaries scan, but the size of the ovaries are normal, is it also considered as PCOS? And what could be the possible line of treatment?
No, it is not. See, if she doesn't have any other criteria for PCOS, especially the age of the girl, they can have multiple follicles. If the follicle should be 2 to 9 millimeters only, it should not be more than 1 millimeter to call it as PCO. Multiple follicles they can have at that age. because a lot of immature follicles, they do it. That's why ultrasound should not be done at all at that age. Okay, until 20 years probably, if you take for diagnosing PCOS. Various other reasons we do ultrasound, but for the diagnosis of PCOS, as I told you, we don't take it as an ultrasound criteria at all. So other things only we have to take. If she has obesity, she has menstrual irregularities, she has got acne or hirsutism, then we think of PCOS. Otherwise, no. Ultrasound alone, ultrasound should not be used at all in adolescents for the diagnosis of PCOS. Yes.
Okay. There's one more question in the chat box. What is the treatment modality for thin PCOS?
Lean PCOS, is it?
Yeah, lean PCOS.
Lean PCOS. Lean PCOS also same thing. Whatever problems they come with, we have to treat here. The additional burden of this overweight and then asking them to do exercise and then the dieting, all that won't be there. But if they have menstrual irregularities, yes, probably we have to treat the menstrual irregularities accordingly. If this is adolescents, the reproductive age group, they may come, usually they come with infertility, then we have to address the problem. But only difference here is they don't have this overweight problem. So we are not counseling for that aspect of it, but whatever problem they come with, we have to attend to that problem.
Okay. One more question, but it is not related to the topic.
Yes, please.
What to do for breast development if the breast tissues has not developed adequately? I think this is not related to the topic.
See, the breast tissue, breast tissue development, we are not worried. See, breast tissue will develop. The only thing, other thing is the fat is there in the breast, and then you have a breast tissue as such. Some people will have a large breast, that is fat accumulation will be there. What we take as thalarchy, there are stages of thalarch. It depends on the mold of the breast and the areola color, nipple, all these things we take into consideration for the breast development. We don't look at the size of the breast to say whether the breast is developed or underdeveloped or normally developed. That is not the criteria. So there is no question of breast not being developed. If the breast doesn't develop, means there is no secondary sexual characters. That means they have some abnormalities in the chromosomal abnormality. We classify them as primary amenorrheas. When they come, we say breast development is there, breast development not there. That means secondary sexual characters are there, they are not there. That means we categorize them so that we know where is the cause for the primary amenorrhea. Breast development is not equal to breast size, please. We have to remember that. Areola is there, areola pigmentation is there, nipple is there, breast mold is there. That is the development of the breast. Tanner staging. We use the Tanner stage for the breast.
Yes,
yeah, next. Any other questions?
There's no other question in the chat box.
Okay.
I once again thanks, ma'am, for your very informative talk on adolescent gynecology. Thank you.
Okay, thanks a lot. I'll thank all of you again for giving me this chance to talk to all these youngsters. Okay, thank you.
Thank you, ma'am.
Okay.
Now I invite our next eminent speaker in today's webinar. She is Professor Fajia Begum. She has completed her BMS from GMC in 1986 and BMS BMC in 1988 and MD from Antioch University of Health Sciences. She is currently working as a HOD department in Qabalat, Amraz, Niswan, and IIM Bangalore. She has more than 20 years of the clinical teaching and research experience. She is honored with various awards like in 2006 Bharatiya Chikitsya Ratan Award, the Economic and Human Resource Development. In 2007, Mother India Award in Health Experience. In 2016, National Award by Ahmed Ashraf Memorial Society. In 2016, Best Paper of the Session at Global Wellness Week. In 2017, Mohsin Natib National Award for Dynamic Contributions in Providing Intervention to Gynaecology at national level. In 2017, she has been awarded with the Honest Services to the Urology System of Medicine. In 2018, Best Teaching Faculty PG level on the occasion of the World Fourth Unani Week. In 2019, she has been credited with the Best Scientific Paper Publication Award. In 2019, Bharat Jyoti Award by Indian International Friendship Society. In 2020, she has been awarded with the Best Research Paper Award by Ministry of Ayush, Government of India. In 2021, she has been awarded with Eminent Teacher Award honored by RGHS, Ministry of Ayush, Government of Karnataka. Her academic achievement includes she has supervised more than 35 PG scholars. She has been credited with publication of 95 research and review papers in various national and international index scientific journals, and she has penned 5 books. She has presented various papers and invited as a guest speaker, chaired scientific sessions in various national and international conferences, workshops, and ROTPs. She is the member of the BOS of RGHS. She is the chairperson of IEC and member of other committees. She is the review member of panel journal of integrated community health. I welcome her in today's webinar on adolescent gynecology. She will speak on the topic common gynecological issues in adolescent girls and its Unani perspective. It's over to Professor Wajia Begum, HOD Ilmul Qabalat to Amraz and Niswan.
Assalamu alaikum. A very good afternoon. Thank you, Dr. Smith, for your kind introduction. My topic of discussion is health of adolescents in current scenario and how Unani medicine and diet management help in controlling or preventing so many health issues in adolescents. Here, my main focus is on some other issues along with gynecological problems. A few conditions we'll miss while evaluating the adolescent patients. Sundari Madam has given a very elaborative lecture on PCOD in adolescents. And nowadays, this condition has become the main focus of adolescent health. As all of you know, prevention in this age makes sense to control many major illnesses in future life. First, with the introduction, I'll start. So, just brief information regarding the adolescence and its classification according to age. So, adolescence from Latin word adolescence to grow into maturity, transition from childhood to adulthood. As per WHO, the age between 10 to 19, either they can be married.
The slide is slightly moving.
Or unmarried. So adolescent girls living in far-flung areas with very little source of income suffer a lot of health problems, apart from the problems suffered by urban and semi-urban adolescents. So generally, adolescent girls transform from childhood to adults. This transition age has got its own problems. They may be summarized as organic problems, which are mainly related to the changes in the reproductive system and the adaptation of girl to the existing environment. So lack of personal hygiene by Horney, there is the theory that is proposed the strategies used to cope with anxiety can be overused, causing them to take on the appearance of needs. So this is a conflict between dependence versus independence. If not properly handled, leads to delinquency, improper social behavior, and mental stress. So Unani system of medicine has got the source of natural drugs. The drugs are available at the doorstep in the form of herbs, shrubs, and trees. Fortunately, most of the drugs related to the problems of adolescent girls are of plant origin, commonly used in culinary and diet. So improvement on diet and small changes in habits will lead to improvement of health status. So with a brief division, adolescence, as you know, between the age of 10 to 19 years as per WHO classification. So early adolescence comes under between 10 to 13 years, middle adolescence 14 to 16 years, late adolescence 17 to 19 years, and youth is 50 to 24 years, and young people 10 to 24 years. So as per Unani concept, Balughat is the pivotal age. It is a transition sign of growth and development which appears at the interval between the childhood and adulthood. So in hot climates, Balughi occurs between the age of 9 to 16 years, but in cold climates, it occurs between the age of 21 to 28 years, it has been mentioned, and in normal climates, it occurs between the age of 12 to 19 years. So stages of age as per according to Unani concept, there are different age stages. The Unani physicians has divided this entire period of life into 4 stages, depending upon the quality of Rutubat gharizia or Rutubat ustastusia, that is protoplasm that is present in the body. So these are known as Sane Namu, Sane Shabab, Sane Kahulat, and Sane Shehukat. So Sane Namu in this period, the Rutubat gharizia over power to Hararat gharizia, it is also known as Sine Hadasat. It is a growing period and continues up to 30 years. During this period, the development of the organ continues. So here, this Sane Nemu is further divided into many stages. So in that Sane Galania, that it extends up to either 19 or 21 years of age. During this period, the child attains maturity. And Sanashibab, it extends from 30 to 35 years or 40 years of age. In this period, Rutubata Gharizya present in the body is just enough to maintain Hararata Gharizya. In this period, there is neither development or nor degeneration of the organs will occur. So here we have to understand the mizaj in the pubertal age. So mizaj in this age group is usually hararat, har or ratab, that is hot and moist. So Hippocrates has postulated the theory of four humus, that is dam, balgam, safra, and sauda, and are called as akhlad. Any derangement in their quantitative and qualitative this thing will leads to disease. Then in India is a home to 243 million adolescents. So children aged 10 to 19 years, the most adolescents of any country. So it accounts for about 21.3% of population of the country. The girls currently married are 30%, and birth by age 18 years is 21.7%. So global adolescent health. So complications that are linked to pregnancy and childbirth are the second cause of death for 15 to 19 years old girls globally. So some 11% of all births worldwide are to girls aged 15 to 19 years, and the vast majority are in low and middle socioeconomic income countries. So 23% of population in India are adolescents. Half of the group is sexually active before marriage. Fertility rate is high in adolescents, causing unsafe motherhood. So, and in this, low knowledge is also has been considered. Then, so what are the major problems that are associated in this age? So general health problems, including precocious puberty or delayed puberty, poor eating habits, skipping meals, overeating habits leads to obesity, menstrual irregularities, primary dysmenorrhea, scanty menses, premenstrual syndrome, hirsutism, PCOS, XY gonadal dysgenesis, anemia and fibroadenoma of breast, and infections. So why the female morbidity is high in this age? So here the early pregnancy is one of the major risks, and infections, that is STIs especially, and running away, suicidal intentions, risk behaviors, substance abuse, early sexual experimentation with multiple partners, depression, school learning problems, and family problems and abuse. So these are the risk factors to cause increased morbidity here. Then here some common adolescence problems we have to discuss. There is due to hormonal changes. There is emotional turmoil causing storm and stress, and conflict of interest with parents, and change of body structure, worried about their physical changes, confused about the changes, and they are embarrassed, and dietary weight problems causing obesity, anorexia nervosa and bulimia is very much common. Psychosexual development, that is higher sexual drive will be seen, causing stressful and confusion in life. Then psychological changes, aware of gender differences, girls often felt afraid or embarrassed or worried of. Then the risky behavior we have to consider here. So here, smoking and drinking is a source of relief for girls in this age, especially when they are very much anxious, for those with depressive symptoms. And using drugs, that is 14% of older girls reported smoking, and eating disorders were a particular risk for girls, and lack of exercise, and many girls that report lack of exercise in this age. Then the important thing what we have to remember here is the problems that are associated with lower socioeconomic status, especially in the country like India, we have to consider here. So nutritional deficiencies and anemia, worm infections are very much common, unhygienic conditions and infections, illiteracy, early marriage and pregnancy, illegal abortions, sexually transmitted diseases, and psychological problems. So especially when the patient comes to us in this age, first we have to focus regarding their socioeconomic condition, and the anemia should be ruled out, and one infection, that is one infestation history should be ruled out, and whether hygienic condition is properly maintained. So that history will itself give how the adolescent is managing that age group. Then coming to the menstrual disorders, Potential consequences to teenage mothers after giving birth, because early marriages, as you know, because by the age of 13 years, 14 years, still it is going on, even with the restriction of 18 years or 21 years. For this technical problem. So menstrual disorders are very much common, like precocious puberty, delayed or interrupted puberty, premenstrual syndrome, dysmenorrhea, menorrhagia, oligomenorrhea, PCOD, fibroadenoma breast. These are the very much commonly found gynecological problems that will be seen in adolescence age group. And the thyroid disorders will also be ruled out in this age. So nowadays we are seeing a lot of cases with thyroid dysfunction. So here, signs of hypothyroidism and hypothyroidism we have to elicit in the patients. So the patient may come with the history of either bradycardia, coarse hair, that is hair loss, delayed relaxation phase of deep tendon reflex, dry, cold, pale skin, goiter, hoarseness, non-fitting edema, puffy eyes, slow movements, slow speech, thinning lateral third of eyebrows will be observed in as signs of hypothyroidism. And symptoms of hyperthyroidism, that is, the patient may give history of sudden weight loss, increased appetite, nervousness, anxiety, irritability, tremors, sweating, changes in menstrual pattern, increased sensitivity to heat, difficult sleeping. So these are the symptoms the patient may come to you. So we have to rule out for thyroid dysfunction. And the other risky behavior that should be counted, that is, as I told in the beginning, smoking and drinking is a source of relief. So this we have to rule out in the patients. And those that is the problems associated with the low socioeconomic, discuss this. Then the main important thing what we have to see here is consequences to teenage mothers after birth. I think I have completed this slide. So all adolescent girls in developing countries suffer from iron deficiency and anemia causing anemia, about 25% with iodine deficiency, which leads to goiter and brain damage in the fetus and infant. So teenagers are physically and emotionally immature for childbearing and rearing, have reduced educational and occupational attainments, lower income, increased welfare dependency. So of all maternal deaths, 25% occurs in the teenage group. Babies born to teenagers are at the higher risk of infant mortality.
I think your slide is not moving. Yes. No, it's not.
So those born to mother aged less than 15 years face increased risk of low birth weight, infant death, and cerebral palsy and learning difficulties. So 51% of girls are sexually active and also concerned for sexually active adolescents in the risk of STDs or STIs. So girls with coital debut before age 16 have twice the risk of PID compared with women who have their first episode after the age of 18 years. So as the immature vaginal examination is more prone to HIV, that is human papillomavirus or HIV infections, if they got pregnant soon, even they are exposed to STIs and unsafe abortions that leads to cervical damage, ending up with malignancies. So teenagers that become pregnant, that is 16 to 19%, and parent, the child may not complete high school, may remain poor. and the risk of genital tract infections will be high. And if they become pregnant, the chances of preterm labor will be high, and the risk of IUGR will be very much high in such girls. So the important component of reproductive health is the safe motherhood, maternal and neonatal health, family planning, adolescent or our youth sexual reproductive health, gender issues, reproductive tract infections, infertility, cancer of reproductive organs, and reproductive health for the elderly persons. Then for the doctors who is able to provide an adolescent with an attentive and safe atmosphere to communicate her health problems and concerns, the rewarding doctor-patient partnership will emerge. The partnership will ensure quality healthcare that is both comprehensible to the patient, which provides the patient sufficient opportunity to be involved in her own preventive care. So understanding the immensity of physical change in adolescence and the psychological transformation, which often safe and trusty dialogue, a healthy enhancing lifestyle accounts by a broad range of healthy behaviors from exercise, diet, and adequate sleep. And this can be enhanced by office-based education. The importance of 3 times meals, mixed diet, fiber diet can improve immunity, which fights against infection should be explained. The various schemes involved in the state as family planning, midday meals programs can favor the maintenance of health of adolescent girls. So what are the complications of early pregnancy? Why pregnancy should be avoided in early stages? So here the complications include pregnancy in PIH, anemia, STIs, preterm birth, obstructed labor, preeclampsia, postpartum depression, low birth weight, prenatal and neonatal mortality, and unsafe abortion practices. So these are the various complications that should be controlled when we are avoiding early pregnancy. Then what are the mental health issues here? So half of all mental illnesses begins by the age of 14, but most cases go undetected and untreated. In terms of burden of the disease among adolescents, depression is the 3rd leading cause and suicide is the 2nd leading cause of death among 15 to 29 years of age. So mental health problems commonly seen are depression and suicide, psychosis, mania, conduct disorder, and anxiety disorder. So what are the contours of the intervention strategies? So these intervention strategies include IEC, that is information, education, and counseling component. This plays a major role in avoiding so many health issues and preventing so many health issues in the school going or college going girls. So interventions by healthcare system at individual level and state implementation schemes or programs should be advocated. So the effect of education in the development of modern adolescent, that is childbearing, is usually lower in better educated women compared to less educated. A multi-program approval that encourage postponing sexual involvement and provides comprehensive sexual education, including accurate information about contraception, utility, impact, adolescence, pregnancy, etc., should be educated properly. Then prevention of adolescent health problems. So primary prevention, how is it is possible? So by making the policies, different policies, national information and education, that is school level information and education is very important. So even in the syllabus, we can add up the important aspects here. Then secondary prevention by identifying the risk factors and reducing the risk factors in that age, and tertiary prevention by treating and by going for rehabilitation health. Then information and counseling. So life skills, the ability of adaptive and positive behavior that enable individuals to deal effectively with the demands and challenges of everyday life as per WHO. And UNICEF also says a behavioral change or behavioral development approach designed to address a balance of three, that is knowledge, attitude, and skill. So what is the life skills? So this to be taught at school level. So critical thinking and creative thinking is important here. Then decision making and problem solving, communication skills and interpersonal relations, coping with emotions and stress. and self-awareness and empathy. So life skill and education are incorporated through schools and communities, outreach sessions by teachers, ANMs, etc., by trained counseling. So what is life skill education? So teaching through participatory learning methods like games, role plays, group discussions, and practicing skills through experimental learning is a non-threatening setting. So it provides individual with wide alternative and creative way of solving problems pertaining to drug use, sexual abuse, teenage pregnancy, early sexual experimentation, and bullying. It is a promotional program which improves positive health and self-esteem. So adolescents in India. So here 19 to 8% of women in age group of 15 to 19 are pregnant in India. The age-specific fertility rate for 15 to 19 years in 107 per thousand, and 59% knows about condoms, 49% knows about OCPs. Contraceptives use among married adolescents is 15 to 19, in the age of 15 to 19 is 7%, and half of them suffer from nutritional anemia, and young people between age of 10 to 25 years make up 50% of all new HIV infections. So this is the scenario in India. So what are the prevention strategies in the care of adolescent girls? So detection and prevention of STIs and prevention of pregnancy by educating the patients, contraceptive devices, etc. is very important. Then prevention of substance abuse like tobacco, alcohol, illicit drugs through education. So nowadays in schools and colleges, the drug addiction has become so much common. It has become a major issue here now that should be very much maintained by proper education in the school, adolescent age group. Maintenance of mental health detection of depression and suicide prevention, and prevention of dysfunctional family and violence by conducive environment, and prevention of nutritional disorders and prevention of sedentary life will play an important role in controlling many health issues. So what are the general prevention strategies in the care of a young adult woman? First, conception control, then prevention of stress, prevention of domestic violence and external violence and their consequences, helping patients learn about a balance between mutual compromise, early recognition of autoimmune disorders like thyroid, lupus, rheumatoid arthritis, etc., and attention to nutritional needs. Then here, few important things we have to remember. If pregnancy in conducting pregnancy prevention programs, so family focused is very important. So improve parent-child communication in an attempt to delay sexually active among teenagers by encouraging parents to promote sexual health. So community focus, so offered pregnancy and contraceptive information to a diverse group of adolescents in order to reinforce messages about the value of abstinence from sexual intercourse and sexual decision making. Then contraceptive advice, access, so improve access to contraceptives for sexually active adolescents through school-linked or school-based health centers and enhance clinical service programs. So life option models, so enhance young people's life option to provide work opportunities for other alternatives to early pregnancy and childbearing. So few adolescent health programs we have to remember, that is Kishore Shakti Yojana, that will help in improving the health and nutrition status of the women. Then Balika Samriddhi Yojana, so this will help in delaying the age of marriage. Then reproductive and child health programs, adolescent friendly health services, and national AIDS control programs. So these are the important programs that are organized by the government, and the NGOs will work on these programs, and they can bring a lot of change by proper educating. Then services in adolescent clinics. So this is very important. So they have established adolescent clinics where what are the things we have to consider there. So after general examination, we have to consider the nutritional advice, we have to detect and treat anemia, and we have to develop, easy and confidential access to MTP and antenatal care and advice regarding childbirth. Yes, detection of STIs and its treatment, HIV detection and counseling, treatment of psychosomatic problems, and de-addiction. These are the important points that we have to keep in mind. And we can keep such clinics in the hospital section, and we have to educate the adolescent age group patients so that they can maintain proper health. Then IEC, that is information education communication component, may be strengthened, and counseling to the girls may be made essential part of field work, wherein various deliberations can be part of the field work, wherein various maybe management of the problems of young girls. So we can start monthly programs of mother and child care at dispensary level for awareness of various useful medicinal plants. Particular mention may be made by medicinal plants used in gynecological disorders and obstetrical care. So prevention is better than cure. So what are the prevention strategies in the care? So here, prevention and detection of STDs can be identified and controlled by maintenance of hygiene and regular gynaecology visits and doing pap smears, and keeping maintaining the hygiene of whole body, that is daily bath, washing of clothes properly, maintaining oral hygiene, and grooming, care of ears, and washing eyes. So all these are important things. And here, now in this scenario, the use of junk food has become a very important issue and a major issue. So this has to be identified and addressed properly. And prevention of nutritional disorders. So balanced diet is very much important, and ask them to avoid bakery items, especially the junk food, and advise to take the healthy foods. We have to address, especially in the school going age group, and the healthy drinks rather than the other soft drinks. They can go for fresh juices, and they have to avoid all these sort of junk foods, especially the oily food, and more of non-vegetables and other things, chocolates, etc. And prevention of sedentary life. This is very important now. So regular exercise. So nowadays it has become a habit. So they'll not sleep timely and adequately also. So adequate and timely sleep is very important to maintain health along with regular exercise. Then prevention of substance abuse through proper education. This can be controlled. And prevention of pregnancy by educating about contraceptive devices, and the early pregnancy should be can be avoided. So nearly half of adolescent girls aged about 15 to 19 years in India are underweight. So with a body mass index of less than 18.5. So UNICEF global database has been found in 2011. And concerned with adolescent nutrition, this is very important. A large proportion of India's adolescents are anemic. So 56% of girls and 30% of boys. Anemia among adolescent girls adversely affects these young people's growth, resistance to infections, cognition development, and work productivity. The National Ministry of Health and Family Welfare launched a national-wide weekly iron and folic acid supplementation program, that is VIFS program, in January 2013, and it is continuing in the school. So along with midday meals, they have started iron and folic acid supplementation daily, along with deworming once in 6 months. So nutritional requirement at different stages of life in healthy women, this we have to consider. And when the life stage is menarche and using contraceptives and all, so at that time, she should increase her iron requirement and decrease serum level of folate, B12, B6 have been observed in some studies, possibly to a dilution effect. So pregnancy and lactation, so increased requirement for iron, folate, zinc, calcium, phosphorus, and protein should be supplemented, and decreased serum levels of albumin, zinc, and water-soluble vitamins due to 50% of expansion of plasma volume that peaks in third trimester. So increased serum levels of copper due to damage in binding of ceruloplasmin. So assessment, see, this is very important. So nutritional assessment and deficiency should be ruled out properly, and proper supplementation will only correct the anemia condition or nutritional deficiencies. So just advising in a general way without monitoring or without checking the blood levels, that will not give a good result. So iron deficiency, as you know, may cause microcytic hypochromic anemia and it will be immunocompromised. So we have to suggest taking liver, meat, egg yolk, legumes, whole enriched grains, dark green vegetables, dark molasses, oysters, etc. So which is rich source of iron, and iodine by supplementing iodized table salt, seafood, water, and vegetables in non-goitrous region. So because the deficiency will add up with cretinism and myxedema. Folic acid deficiency will cause megaloblastic defect of red blood cells, and that folic acid is rich in liver, kidney, beans, limba beans, fresh green leafy vegetables, wheat, lentils, etc. So vitamin A, fresh green leafy vegetables. So because when we are able to advise proper diet, proper balanced diet, having rich source of iron, iodine, or folic acid, whatever, so we can prevent all these problems. So that should be assessed properly. Then weekly iron and folic acid supplementation, as I was telling. So this scheme is community-based intervention, addresses nutritional anemia among adolescents and covers adolescents in class 6 to 12. So the key features here: weekly supervised administration of iron folic acid, that is iron of 100 milligram and folic acid 500 micrograms, and screening of target groups of anemia and referral, and biannual deworming. So information and counseling for improved dietary intake and prevention of worm infestation will be helpful. So this reproductive maternal newborn child health plus adolescent health strategy that promotes link between various interventions across thematic areas to enhance coverage throughout the life cycle to improve child survival in India. This program is under NHM. So by adolescent nutrition and IFS supplementation, facility-based adolescent reproductive and sexual reproductive health and other health issues, information and counseling, and menstrual hygiene, and preventive health checkups are very much useful. So dietary, that is recommended dietary intake. So here we know the normal calories, vitamins, calcium, iron, zinc, how much they want. So how much we have to increase, this chart is very much useful. So in pregnancy and lactation, we have to increase the calories, proteins, everything. Then only we can fulfill the demand. So few dietary guidelines we have to follow here. So here, what is the healthy diet? Here we have to advise to eat 3 meals. So nowadays skipping meals has become a habit, and usually 1 or 2 meals with odd timings they are taking, and that is not good for their health. And healthy snacks can be advised. Increase fiber in the diet and decrease the use of salt. Plenty of water should be taken, and balanced meals should be given. And cooking for young adolescents, especially, try to bake or broil instead of frying. So make sure your adolescent watches his or her sugar intake. So sugar intake should be lessened, especially in this age. So here we have to advise to take variety of food, balance the food they eat with physical activity, maintain or improve weight, choose a diet low plenty of grains, products, vegetables, and fruits. Choose a diet moderate in salt and sodium. If they drink alcohol beverages, do so in moderation. So diet rich in fruits and vegetables have been shown to be correlated with positive health outcomes, so including decreased cardiovascular disease, so lowered risk for certain cancers, and healthy people. That is, it was then in 2010. So, and 3 daily servings of vegetables with at least 1 serving of vegetable involving a dark green and leafy or orange vegetables is rich, that is nutrient rich vegetable. So dietary preference and intake patterns are essential in childhood, and experts have focused on changing children's diet in effort to improve health, but during childhood and over the long term. So only a minority of children have been found to meet the healthy people 2010 objective, and in spite of an increasing need for certain micronutrients contained in these foods. So few Unani intervention strategies we will discuss here. So anemia and irregular menses in the patient may come with you. So iron and folic acid with vitamin A and uterine tonics for menstrual regulation will be advised. And for infections, deworm with Fusebidan, STDs, proper education and condom promotion, infection, maintenance of hygiene and immunity improvement supplements. So rich in folic acid vegetables. So this is a very important. See these gobi leaves, gajar, sapota, pyaz ki patti, खीरा, अंगूर, narangi, tomato, jawar, bajra, desi besan, or spinach, lettuce, all are very rich source of folic acid. And the iron rich source is methi, greens, anar, kela, anjeer, popcorn, fennel, lima beans, parsley, water trees. So all are rich in iron content. So we have to suggest these because usually in this, especially in the adolescence age, the girls, they don't want to take any vegetables or fruits. They usually avoid. So iodized salt is rich in iodine. Even that salt should be advised in their diet. So few compound formulations that we have suggest for our patients in this age, especially that is rich in iron and this calcium and all. Kurse folad, Jawarish jalunus, Samira marvari, Cherbat folad, Labu bekabir, Cherbat anar, Majunus paripak, Pushte bezur. So these are the very good supportive formulations that will help. So here in immune system of medicine, a wide drug base of natural origin. So plants and plant products may be used as supplements and complements in the diets of adolescent girls. So use of common vegetables like carrot and turnip surely may supplement vitamins and minerals intake that are necessary for a healthy status of body. So midday meals must be recommended with the regional flavor where we can add the cheapest and commonest plant products and that season of that season and region for their team supplement. So it will not furnish the requisite need for adolescent, but will make midday meals cost effective. Advising Kurse Pola along with midday meals and Kurse Diyan once in 6 months play a major role in preventing major adolescent health hazards of girls. So for anemia, as you know, as I have discussed all this, so we can give Unani supplementations. Then this I have already told. So this is the this are irregular menses. Infestation, this I have mentioned already, and infection control with proper education and condom promotion and proper hygiene maintenance is very important here. And if the adolescent is pregnant, so very much care should be taken considering this case as high risk, and we have to give proper guidance and proper support to complete her pregnancy without any complications. So take care of your body. It is the only place you have to live. Thank you for being with me. Thank you once again.
Thank you, Professor Vajja Begum, for highlighting the various health issues at the adolescence and including its management, right from the beginning of description of the age according to the Unani system of medicines, prevention of the health, various health issues during the adolescence period, what adolescent healthcare programs can be conducted to improve the health of the adolescents, various mother and child care programs that can be conducted again to tackle such type of issues during the adolescence, preventions and detections of the STDs, especially at sexually active at the young age, nutritional supplementations in adolescents to improve the iron deficiency anemia, various reproductive and child health care strategies that can be conducted to overcome these problems, and finally the various compound inorganic formulation that can be used to tackle the various health issues that occur during the adolescence. Thank you once again for giving a detailed deliberations on talk on adolescent gynecology. If participant has any query, they can post the question in the chat box. Or they can raise a hand. I think there is no. Yes, please. I think there is no query. Now it's the time for vote of thanks. So for vote of thanks, I will call upon Dr. Arsha Sultanu working as an associate professor in the Department of Ilmul, Qabalat, Amraz, Niswan, National University Medicine, Bangalore. It's over to Dr. Ashya Sultana.
Thank you, Professor Ismat, Shami Madam. Before proposing vote of thanks, I request all the delegates to kindly fill the feedback form so that you can get your e-certificate. On behalf of organizing team, it's my privilege to propose vote of thanks on this occasion. Let me first of all start by giving glory to Almighty for making today's webinar a resounding success. My heart fills with lots of gratitude and respect for our distinguished guest speaker, Professor N. Sundari Madam, retired HOD, MS Ramaiah Hospital, for not only sparing her invaluable time for us, but also for enlightening us with her commendable talk on the very important subject, PCODs. Thank you a lot, Madam, for enhancing and understanding the subject. I also express my heartfelt thanks to our beloved director and organizing chairperson, Professor Abdul Sir, and our in charge Director, Professor Zulkif Sir, for his valuable contribution and continuous support to conduct this webinar. I also thank our HOD, Professor Vajia Madam, for her untiring efforts, excellent presentation, thus making this webinar a fulfilling one. My heartfelt thanks to all our faculties, our organizer, for the valuable contribution and efforts. Last but not the least, I am thankful to our PG scholars of Gynec department, doctors, and delegates for attending this webinar and making it a great success. Thanks for patient listening.
Thank you, Dr. Ashya Sultana, for thanks. With this, we come to the webinar. Thank you once and all.
Coffee now.